continuing our rotation from the short axis view where the marker points towards the left shoulder of our patient, we rotate the transducer so that the marker points cranially. And then you have the view of the IVC. Of course, the IVC is a little bit more located towards the right side of the patient, whereas the aorta is normally a little bit more localized towards the left side of the patient. Here I have such an example where you optimally see the inferior vena cava, here the right atrium. Here you see the collapsibility while this patient is inhaling. So the collapsibility is also very important for volume status, but this is the topic of the volume status dedicated chapter. Why is it important by means of right atrial pressure? Well, again, it's the collapsibility. So if it's not collapsing at all, the right atrial pressures are normally higher compared when it's really nicely collapsible, as in this case. Also, the SVC can be visualized. The SVC is a continuation of the IVC. And of course, you can take a look if you see a right-sided protrusion, which already gives you a hint towards what you will scan when you're performing lung ultrasound. In this case, we also want to focus on this artifact. You see here the heart, this trivial pericardial fluid. So this is not a pericardial effusion, simply normal amounts of free fluid. You see the inferior vena cava, which also doesn't look pathological. This is the liver, the portal venous system. And here in the area where you would suppose that there are lungs, you do see it's like a second heart. Of course, it's not a heart. It's here this hyperechoic line, which is representing a mirror. So this is a mirror artifact. The pericardium, the lungs per se, so the pleural line and the diaphragm, they can act as mirrors and create those artifacts where the machine simply thinks that the structures from the scanning above this highly reflective zone continues into the depth as well. But this is not pathological, it's simply an artifact. Another structure, we already talked about it briefly, is the Eustachian valve. So this is a normal structure you have in the embryological state, so you actually need it, but at some point it's not a real valve anymore. It's just very often a structure you can find which is always connected to the IVC, and it doesn't have a pathological nor an anatomical function. Sometimes in very, very rare cases you can find an endocarditis there, but so far in my entire echocardiographic life, I have never seen that. Eustachian valve you see over here, sometimes it can be really prominent and really large, but it always originates at the IVC. In this case, we have a dilated inferior vena cava and there is practically no collapsibility during respiration. So this is not an intubated patient. This shows hypervolemia. Also, if you take a look over here, there is pleural effusion present, and using color Doppler, you do see this change in red and blue color, even though there is a normal PRF optimized for echocardiography. So this indicates tricuspid regurgitation, relevant tricuspid regurgitation, and also it can indicate elevated right atrial pressures. This is very important when we talk about measuring and visualizing the flow of the hepatic veins, for example, in constrictive pericarditis, but also when we are performing a VEXUS protocol. So it gives us already hints about volume status and many other pathologies as well. This is a case, sometimes you see it in echocardiography. It's not something you want to see. So this is a patient with renal cell carcinoma. It was not known before, but what was apparent in this first view of the subcostal approach, you see that the IVC is filled with a mass. So this is a tumor thrombus formation in the IVC in a patient that turned out to have renal cell carcinoma. So this is something you truly do not want to find in your echocardiographic exam. Unfortunately, it happens from time to time that you are the first one to describe this mass. Continuing in the subcostal approach, we can also scan the liver veins. So we can continue our rotation or we can stay in the same angulation. If we continue our rotation, we can see all the three liver veins. Here's the right, the left, and the intermediate. So there are three, and for the VEXUS, for example, you need one who is optimally located towards the transducer to perform measurements. So this is also called the star of the liver vein. So this is the inferior vena cava entering the right atrium. This is the interatrial septum. And then you have the liver veins here. Don't confuse this with a vein. This is actually portal venous system. With the liver veins, you can use, of course, the B-mode image and just sweep through the liver veins to see how large they are, if they are small, normal in size. So approximately in this area, it should be around 7 millimeters. If it is larger than 7 millimeters, there could be congestion. In this case, we do see that the liver veins, all of them are definitely enlarged. And this is the patient with heart failure, the flow backwards, where you see this change in red and blue color, which indicates relevant tricuspid regurgitation and elevation of right atrial pressures. Previously discussed, the IVC continues, or the continuation of the IVC is the SVC. You can use it to see the IVC also. Sometimes in this view you get an optimal differentiation of this hepatic vein, and here the entering of the IVC into the right atrium. This is the tricuspid valve. Here we have the Eustachian valve, a very prominent Eustachian valve. And the continuation of the IVC is the SVC, the superior vena cava. You can look at the collapsibility as well. Like the IVC, of course, the SVC has to collapse, but you get a better delineation of the SVC in transesophageal echocardiography compared to TTE. Showing color Doppler, here's the IVC, the right atrium, trivial tricuspid regurgitation, and the SVC as the continuation of the IVC. We can continue and now move towards the aorta. Continuing from the IVC, we can also scan the aorta. So with the SVC is the continuation of the IVC. Sometimes you still have to rotate a little bit,